studied hypnosis as well. He was a student of Dr. Palan here, and in US also he studied hypnosis. And he's a certified hypnotherapist by American Council of Hypnotist Examiners. What I remember, and you all must be knowing that he has taken 2 lectures in our PGDCH course as well. And it is about performance enhancing and hypnosis. And today, Nikesh is going to share with us how he helped a person who was, suffering from phobia, and that he is going to share with us with hypnosis, how he used hypnosis and helped the person. So, Nikesh, over to you. Thank you.
Just a couple of things. Thank you very much first for the introduction. Couple of things I would just like to add.
Yeah, sure.
You mentioned I was a student of Dr. Palan. I would just like to uh, clarify that that is correct. And I am today also, I am a student of Dr. Palan. So that is,
Absolutely. We all are students of sir. I
ha,
mean, yeah.
yes. So that is one. And second part, the sir had given me privilege to and encouraged me to prepare this earlier faculty presentation about role of hypnosis in management and leadership. So that those were the I think a couple of topics. Some of you may be familiar with. Some of you may have remembered me in purple color shirt video or some glimpses of my presentation. But here am I again. And today's topic is I would like to share a case study of an old lady who was, in fact, in her entire life, she had never swallowed a single tablet. She had a phobia of swallowing tablet. So I would like to uh, present this case study um, that how with these tools and techniques of hypnosis that we have all learned, I was able to apply that. Okay. This patient is 70 plus years senior lady, very active even at this age. And she has some basic understanding of hypnosis. And she has positive impressions about hypnosis. The problem statement is phobia of swallowing tablets. We may have heard, some people in childhood have a little bit difficulty of swallowing tablets, but as they grow old, they usually take tablets with water and they swallow it easily and comfortably. This person had never swallowed any tablet in her lifetime. She had this phobia. Now, this patient has been on blood pressure medication. So, there is a genuine need. However, even for that, she could not swallow the tablet and hence had to make a powder and then drink with water. So, this was the problem statement or the condition of the person. Now the impact of this limitation was that it was major inconvenience for her. Wherever she had to travel, or go even for a short trip where the window is lying during the tablet time, it would become very difficult for her. So it was limiting in a way her quality of life also.
Yeah.
Of course, it was an inconvenience. And also, it is not just blood pressure tablet. That is just the essential one. She was also deprived of taking any vitamins and other supplements that doctors may suggest or prescribe her due to this limitation. So the impact was in a way pervasive in terms of her ability to take supplements or any kind of medication. During the first meeting, I had, of course, gathered this knowledge about this problem statement before the meeting. But when I met the patient in person, I had in my mind that there are a couple of things I would include in my plan. And the first session was systematic desensitization. And the second session in the plan was to program the subconscious mind to accept pills healthfully and successfully. And to start with relatively smaller tablet size, I will correct the typo, as the subconscious would allow her. Now, I was told by her in the pre-session counseling discussion that this BP tablet, इतना छोटा है फिर भी नहीं ले जा सकता है. She had exclaimed that. However, my interest was to even to grow beyond that need and also help her to take even different sizes of tablets. Hence, in the second session, my plan was to use the word relatively smaller tablet size, just so that it becomes at least uh, a clear uh, path for the blood pressure tablet. And I had some thoughts about um, shape and size and flavor and things like that to add to customize to her choice. So this was the plan before the first session was conducted. Any questions so far? Do we take questions in the end? How does it work?
End.
Okay.
End.
So session 1, the focus was systematic desensitization. Duration was 20 minutes. Induction technique I used was the eye fixation and mind distraction. After induction, 2 scenes are used alternatively. One is patient's favorite scene, which I had gathered in the pre-meeting counseling, and she had given some ideas. And we talked about that, one of the most favorite scene. And then second image, the scene is patient sitting inside that favorite place, which is her favorite place, a beach in this case. And in that beach, in the background, there is a freshwater waterfall, and she sitting on the table and taking the pill. So these are the two scenes alternatively used. The ratio of duration for favorite scene to the pill swallowing image is 40 second to 10 second. So 40 second, I had her just enjoying the favorite scene at the beach and the background of waterfall and exactly what she loves. And the remaining 10 second, she's still in the same scene. However, she's taking the tablet. And we shifted this about 6 times, meaning we repeated this about 6 times. 40 seconds favorite scene, 10 seconds swallowing the pill, and then repeat the same cycle for about 6 times. As you may notice, the duration of swallowing the pill is much smaller. And this was the session, and then brought the patient back from the trance or hypnotic state. This was session 1. In the same weekend, the next day, the second session was conducted. The feedback of session 1 was very positive according to uh, that senior lady, and she was ready. It seemed she was ready to go for session 2. So second session, the focus was kind of what we learned uh, from Palansar, kind of an SIC. And here, uh, the theme was that patient is watching the movie with favorite scene is there in the movie and taking the medication. Okay. This was about 11 minutes session. Here also the session breakdown: first hypnotic induction, eye fixation and mind distraction technique, revisiting patient's favorite scene, and having patient watch that movie with my guidance that she is taking this blood pressure medicine successfully and healthfully. And I had also explained to her about idiomotor signals. Yes finger and no finger was explained to her. Her yes finger was index finger and no finger was the pinky finger. And she was monitored during this process of she watching that movie. And after I found that she completed this movie, healthfully and successfully, I brought the patient back. And given that she was very optimistic and upbeat about this experience, I had, with her doctor's prior permission, I had asked to offer tablet uh, just after the session. And she had taken that tablet comfortably and successfully. So this is how the session 2 was culminated in a practical after the session. Overall, the outcome has been that it's about 45 days now and counting. Patient is able to swallow the blood pressure tablet daily with water in a comfortable, healthy, and successful manner. And if I just need to articulate patient's own words, she had said, "Thank you so much. I swallow my BP tablet regularly, and I have been following up with her every week. And maybe in a couple of weeks or so, I may need to check and find out to expand onto other tablets that she may like to explore and uh, potentially help her out if needed." So this is my case study. It is completed as far as my explanation is concerned. I welcome any questions, thoughts, comments.
Can I ask a question, sir?
Yes, please.
My name is Dr. Rajiv. I'm a medical practitioner. I'm into mental health now and into hypnosis. My first question to you is, when you give the session 1 and the session 2, does the patient imagine that she's taking the tablets, or the tablets are really given to her and she takes it in hypnosis?
In the first session, she is imagining. She is seeing a scene. So she's seeing two scenes. 40-second scene is just enjoying that wonderful, pleasant beach that she loves and her favorite place. And the remaining smaller interval, she's watching herself in her imagination taking the tablet.
Is it an imagination, or she's taking the tablet, really taking the tablet?
So she is visualizing herself as taking the tablet. Pooja, madam, also had raised a hand, but please, sir, go ahead. Finish your thought.
Yeah. The second session, there is a word which you used known as SIC. What does SIC stand for?
It is basically a sensory imagery conditioning.
Okay. Then the third thing is, when you, with the permission of the doctor,
Yeah.
when you give the tablet for blood pressure,
Yeah.
is it flavored with her favorite strawberry flavor, or you're giving without it?
I am giving without it. I'm giving without it. I have um, um, I have already told her after the session that here is the tablet now. and would you be open to take it? And she took it. Now, in her mind, whether she had strawberry flavor in mind or not, I am not sure when she took the tablet after the session 2.
Is there anything wrong if we add a strawberry flavor when we give the tablet to the? What is your impression about it as a hypnotist? Since she has imagined the strawberry flavor, and if we give the strawberry flavor in the first attempt, will that facilitate our fulfill our idea to treat with the phobia, or not required?
It depends. If intuitively her subconscious guided me that she is ready, her subconscious is ready to take that tablet. Now, if there was a sense of hesitancy or inhibition, it would have been also a second option.
What did you say, SIC, sir? Once again, can you please tell me what does
Sensory
SIC?
imagery conditioning.
Sensory imagery conditioning.
Yeah.
Thank you. Thank you very much.
Welcome very much, sir. Yes, Pooja, madam. Good evening and so good to see you.
Good evening, Niket sir. How are you?
I'm
Good.
fine with all your
Nice case.
friendship
Nice.
and support.
No, very nice case. Thank you so much for sharing. I just had one question. Was any session with any kind of breathing awareness, PMR, or ego strengthening done before this, or directly the first session was with the imagination? So it was just hypnotherapy, or there was any kind of PMR or ego strengthening done before that?
Just 2 sessions. First,
Okay, great.
First session and second session.
Okay, excellent.
Introduction,
Okay.
programming.
That is American style. People
Right.
don't have much time.
Right, sir.
So,
Okay. Okay,
and
okay. Thank
here
you.
also,
Thank you, Niket, sir.
here also people
Yes.
do.
We are
So-
just probably used to doing it, sir. I don't know, like even when I get any patients of this kind, not phobia exactly, but with any issues, probably I'm just conditioned to use the PMR and ego strengthening first, and then after 15 days only we will take up that issue. But what my observation personally till now in my little experience is that a lot of the issue gets solved only with this much. Then what remains is only that 20-30%. So then I personally feel I'm more comfortable working like that, because then most of it is already solved. Then I have very little to work on. It's not so rigid. The mindset becomes a little loosened up, and then whatever we have to do in hypnosis is lesser work. But that's my personal opinion. So thank you, Niket sir, for sharing this. Thank you.
By the way, I would be very open to have that PMR, breathing awareness, ego strengthening in initial session. However, uh, the this senior lady that I'm talking about had some good uh, respect for guided meditation and hypnosis as such,
Okay.
and uh, uh, you know uh, the readiness to and the trust was high in my perception to address this. Now, um, she did not insist about when she wanted to get it addressed. Meaning, she did not have any goal as such. She just had this problem. And uh, it was my call. I made that choice
That's
that
perfect. That's yeah.
this is the plan. I will work with her and see what I can learn and adapt and help her out any further to enhance her quality of life.
That's great. I think the ultimate goal is just to make the patient's life better. So you achieved that goal anyhow. Anyways, thank you. Thank you so much.
Hopefully,
Niket,
yes. Hopefully it sustains for a longer time and her subconscious did the job, as sir says.
yeah,
Yes.
Niket, we
Can I, yeah.
just a moment. Can we put off this slideshow? This is not required. PPT, so that we all can see each other. Right. Thank you. Please, Dr. Rajiv.
Yeah, I wanted to add a point to what Pooja Madam was telling with the permission of Nikit sir. It is always better to do a suggestibility test before hypnosis so that we are able to assess how best our hypnosis is going to work. There are a number of tests available in NLP and other things for the suggestibility test. Like Madam was mentioning about PMR and ego strengthening. And Nikit sir had mentioned that his perception had told him that his subconscious mind will be able to take whatever is being told. But as a practice, doing a suggestibility test, as we know that it's only 60% or even lesser of the people whom we can really hypnotize, would be a good point taken by all of us as hypnotists, hypnotic psychotherapists, is my point. Dr. Palan can please add to what I had to say.
Yeah, Dr. Rajiv, if like this is how I have understood it, that hypnotizability test also can be done, not only suggestibility, but for publication of the paper, it is a must generally. If you want to academically publish it in a good journal. Practically, your like perception subjectively when you feel that the client is already highly motivated and positive about using hypnosis and all, then it is not mandatory, it is not very much necessary to do the testing unless you have academic interest. That is what I told you. And regarding breathing awareness, PMR, ego strengthening, and all, also when there is a like short-term small goal, one can go like this. Many people go like this, directly hitting the target, and within a couple of sessions, finishing the job. Only thing, my like as I developed, as I grew as a therapist in hypnosis, I my observation was that if we have done this type of work, there are more chances of relapse. Many people used to come with relapse or symptom substitution after a few weeks or a few months. While when I started going slow, whenever it permits, like if the client is in a hurry to get rid of it or hurry to don't have much time to do thorough work, then we do it like this, but very rarely. Otherwise, going slow and then hitting the main target after a few weeks, and before that, preparing the client, that that gives more permanent outcome, more long-lasting outcome. And many times it has happened that the issue which the client has brought initially, that remains aside, that it is already achieved, but so many other things come out, other stressors and various other things out of this our communication and all. So then the client is treated holistically. That is what I found when we go little slow and hit the main target later. But that is how we are able to convey and convince the client for spending so many sessions, like 4, 5, 6 sessions. Because generally people do one session, 2 session like that, and they publicize also that way, 2 session or 1 session, cessation of smoking, like that. So there, this kind of approach may not also work. Client with that kind of mindset. But yes, testing is not always necessary in clinical practice. That is what I have understood. Earlier, in the beginning of my career, I used to do some brief testing, like the Spiegel's eye roll sign. So within a minute, we can find out, or one any phenomena, any arm levitation or something you do, so that you are convinced and the client is also convinced, yes, it is some different state. So that is how I do it generally. Okay. So yes, Veena, you have a question.
No, sir, I don't have a question. I wanted to add one more point to what you were mentioning. When clients have a affinity for meditation, or they generally have some breathing exercise in their routine, then they also have easy hypnotizability. So prior experience or exposure gives them a better responsiveness to hypnosis.
I agree with you. Okay, good. Well, so
Is there
somebody
anything
else?
wrong? Is there anything wrong in doing it, sir? Is there anything wrong in if you are able to do, you do nothing wrong? It's not if you can do a test, nothing wrong in that, no?
Nothing wrong, nothing wrong.
Right,
Testing
right.
is always like it gives more clarity to you also gradually. If you
Right.
do testing in all clients,
Right.
you understand the psychopathology also in a better way. There are many advantages of doing it. In fact, nothing wrong. Renu madam, anything? Or I would invite Dr. Rakesh ji, please.
Anisa, so I go with you that I think that the work is done on symptom removal rather than the dynamics of that phobia. To us, it could be the first question that why the client has developed the phobia in the first place itself. And as Dr. Pooja has also said, that in the beginning, 2, 3 session goes to explore these kind of dynamics and factors. So this is like on my part. So generally, I don't know. I can say or address it as a symptom removal rather than working on dynamics. And then second thing, what Dr. Rajiv has said, that though the 60% people are only hypnotizable, but again, the individual variations are within that group also. So if the person falls at the lower side of this continuum, in that case, generally we say that relatively more sessions are required than the clients, those who are on a upper side kind of continuum. So that difference is there, but it doesn't mean that we don't test or we don't apply hypnosis or hypnotherapy on these people. So thank you. It was really, it's that way it's very fascinating in 2 sessions, and that is also of 10,
So
20.
by the way, that lady does not even, matlab consciously, she does not recall in my initial talk before the first session that since when she had this concern. Um, um, because since it could be childhood, or it could be certain age, but there was no recollection in that. So um, my uh, uh, my thought process was to um, have the the address the immediate need was my main thought process, and her ask was to address the need, which was to ये tablet लेन ये powder करना पड़ता है हर रोज, it's very inconvenient, and so the whole motivation for the therapy was to essentially to take this medication.
Yes, Dr. Niket, you are right in that way, because ultimately, when the client is cured, we are happy and we feel good about it. Um, uh, so that is the one part. As again, Dr. Rajiv was saying ki whether that suggestibility test or hypnotizability test is to be taken or not. So in the same here, that as a therapist, the success or the cure is our main intention, rather than going through or the other aspect which we are discussing here.
I politely disagree that
Nahi, let me
uh,
complete.
huh,
That
meaning
when
no, meaning I politely disagree on the part to go to the root of the phobia in this case. And there could be another example for, let's say, uh, a person has fear of height and is not able to go up to, let's say, uh, more than, you know, let's say 11 or 10 floor, for example, just as an example. Uh, uh, Now, of course, one can study and try to find out through pre-session counseling and all. However, um, the technique could, if it could alleviate that particular concern, uh, it it would be helpful to add the quality of that person's life. Now, I also acknowledge what Dr. Palan sir said, which is important, is that you want to make sure that the changes are long lasting, meaning that should be the goal and the intention. Now, that part is always is going to be a um, um, you know different in various conditions that we may come across as hypnotherapist. In smoking, it could be different. In meaning in addiction, it could be different. In such kind of fear and phobia, it could be different. Because if you think about addictions, there could be triggers that would potentially make person go smoke. However, when there are no external triggers in terms of circumstantial or personal or professional career challenges without any of those stimulus, if there is a condition, let's say just to go up to 11th floor in elevator or take a swallow tablet, where there are no external situations that are making that phenomena trigger, in those kind of issues, I believe one may go with uh, with uh, with the reverse of the funnel, meaning initially go with that narrow, and then in case if there is something to be learned, um, broaden it out and see what are the learnings. Whereas if there are other situations, like we talked about, then broadening to going narrow into the problem may be more efficient, I would say the word. I'm not, I will monitor and report to all of us that how are the outcome in long run. But this is just my thinking at this point. I will continue to learn and share what I find out as far as this case study is concerned.
Thank you. Yes, there are some more questions, Nivedita. And
Uh,
I would
yes,
wish
sir.
Dr. Rakesh
Yeah.
ji, before you leave, you will comment. Rakesh ji,
Yes, sir. Yes, sir.
please.
Sir, I have a question.
Yeah.
Good evening, all of you. One, because she's a 70-year-old woman, was there any, any condition of swallowing issues, dysphagia, something that
No.
that was reported? Yeah.
Good question. No, that was ruled out.
Okay. And
Meaning,
second, I mean,
meaning no neurological or any other condition
because
that
70-year-old and
oh yeah, that could potentially harm that lady taking the medication. Correct.
And I somewhere again, rather I will use your own words, Niket sir, that I politely would like to disagree with the fact that one need not know the trigger or the source from where the phobia started, because I don't know. Speaking from personal experience, I have this personal experience of swallowing medications.
Mhm.
I've had issues with swallowing capsules because
No,
capsules being no. I'm just.
what I mentioned was that
Hmm,
in this particular case,
hmm,
the the based on what client history was,
hmm.
it was determined that there was no need to.
No, I don't. Somewhere I'm sorry, sir, but the fact that I don't know. I'm just that's what I wanted to narrate or relate my personal
Oh,
experience.
sure, sure.
So wherein I was like, I've had issues with swallowing capsules. Capsules being lighter than the solid tablets. Whenever I used to try to swallow capsules, I've had a lot of what is incidents where either the water would go into the nose pipe, and so much. So much generating so much of pain. So every time when a doctor prescribes a capsule, I say, if possible, can you replace it with the medicine's actual, what I meant to say, solid ones instead of the capsule nature tablet. So I'm somewhere these, because I can relate. When I at this age I have had these issues. I'm sure the 70-year-old woman would have felt it even more traumatic or even more painful.
So
So
since
I'm.
last 45 days,
Hmm. No, I'm just saying there would have been
so
some
far,
source. Sorry, yeah.
no, I'm just saying the outcome. So far, so good, and I'm willing to learn actually. If there is something um, I learn about this case, I would be the happiest person to share. And again, the person is taking it willingly every day without any reminders and any extra motivation. I'm just checking weekly in an indirect manner. I'm just checking with her about how is she doing. And then I'm just saying that to her that hopefully all the routine and everything is going on well. And she would mention that, and yes, and I'm also taking my BP tablet regularly. So so far it is encouraging, and I think my goal is to work with her and also find out if she is interested to take any other tablet or anything else in that she would like to take. And I will get back to you if that requires any session or not. But I will get back to you on how that goes. But thank you for
Sanjay?
your inputs. Yeah.
Thank you, sir. Thank you, sir. And congratulations on the outcome. But yeah, still, I would
It is
still
her
again
subconscious
re-emphasize on
mind
understanding the source.
that did the job. I'm thankful that I was instrumental to help her out.
Good. Dr. Sanjay.
Hello, a very nice case. I want to share similar experience and for taking this case further. I had similar case about quite a few years back. And when that particular person was actually making the tablet in a powder form and was consuming. And to the surprise, whole family was doing something like this here. When that case was explored, one deep-seated childhood experience came. When the child was around, say, 5 years old, what happened? Mother gave the tablet like this here, and that tablet was exactly fitting on the glottis. Then what she did, she just means पूरा उल्टा किया उसको and just make it just sums at the chest and then tablet come out. But that was a very severe threatening experience for the child. And since then, because it was a survival experience, whole family was perturbed. And then this was gradually explored this way. So sometimes this life-threatening experience may imbibe in the mind of the child, and therefore this tablet swallowing become a very difficult process. Which
And
they
was
will
that
never let
trauma, you found that out during regression or just counseling?
I was asking you what was the reason behind why you do like
Oh,
this.
I see, I see.
He said then he narrated that experience, and he also told that whole of the family is doing the same way, and till today they are doing. Till today they are doing because the patient is very nearby, but till today that. This is how something deep-seated memories which are very survival they remain there. So it's good to explore this also in such case because the results in 2 sessions may be too short to experience. When they recur,
No, as I mentioned, I explored in counseling. I could not find anything that she had recollection about any such concern. All she mentioned that since childhood, I don't even remember, but I don't take, I cannot take it. I don't take, I don't swallow. That's all. So I decided not to go into regression for exploring that.
Very nice. राकेश जी कुछ बताइए. We want to learn something from you.
Namaskar, sir.
Yeah.
Jay, sir. Very interesting case. So regarding suggestibility, sir, I have my own ideas. If a person is with such problems, they are already hypnotized.
Negative self-hypnosis.
Yes, sir.
Right.
If already hypnotized, that means certainly has hypnotic potentials. So our task is to de-hypnotize.
Yeah.
That is my understanding, sir.
Exactly. I tell it negative self-hypnosis is to be converted into positive self-hypnosis.
Yes, sir.
Person is already in hypnosis.
Yes. Sir.
And further, anything about this?
Yes, sir. Yes, sir. And regarding this, that at conscious levels, it did not have any memory how it started. So we have theories understanding how phobias are acquired. So by classical conditioning, the pairing with some unconditioned stimulus, then observing others, or information fed by someone. So there are some sources of acquisition of phobia. So maybe in childhood or somewhere, if we analyze it psychodynamically, there must have been some learning at subconscious level. And through this wonderful restructuring of this sort test nature, so he could successfully achieve the goal. So it is fantastic and learning for all of us also that we can go
Again,
this way
her
also.
subconscious did the job.
Yes,
So,
exactly that. Problem was with subconscious, and subconscious resolved with your guidance, your suggestions.
whatever I've learned from Palan sir and all these teachers I have learned, I
Yes,
try to apply it.
exactly. That resistance or negative learning at subconscious level, you're successfully associated with pleasant,
I
positive.
think one thing I would like to add is that um, you know, um, for reasons of uh, patients' privacy and confidentiality, I'm not, um, but I think, let me say, meaning name and all, I'm not saying, but how do I say what I want to say? The person is working professional, and um, she believes in meditation, and uh, she is motivated, and that those three factors um, made me believe that
Niket, it is okay, it is fine. You need not to explain or any further explanations are not required why you did not do exploration.
Okay.
But we are all learning that
Sure.
yes, so we can go like this, and many people go. Most of the hypnotherapists go like this, so you don't bother about it.
Okay.
Yeah. So let Rakesh complete.
Yes, sir. Whatever he added, these are the good prognostic factors.
Yeah.
Of well-established occupation, motivation. These are good prognostic factors. The main point, what I am seeing is that there was some learning at subconscious level, and with the restructuring, imagery restructuring, guidance, that resistance got resolved very fast, very quickly. And with respect to relapse, so far there is no relapse. In case there is relapse, then we certainly need to reanalyze the psychodynamics of the case. Then we can go in a more comprehensive, detailed way. Yeah. If there is symptom substitution or relapse. So that warrants for psychodynamic understanding of the case. So I would like to congratulate him for helping her, this old lady, in a successful way. Thank you very much, sir.
Thank you so much.
So thank you.
I have a question, sir. I have a question to ask, sir. When you say that the negative suggestibility test itself is a positive cue for hypnosis, myself being a medical practitioner with different armamentariums with me, hypnotic psychotherapy being the final nail which is going to work, I will use it very cautiously after exploring all other avenues I have in my armamentarium, because I know that we can also, like in specialties, they do investigation under anesthesia, this kind of stuff. We can also use other cognitive behavioral therapeutic avenues, what is available with us. That is why if I get, and like Dr. Nikit was mentioning that he did not find a reason to do it, so therefore he didn't do it. Absolutely, he is perfectly right, because his gut feeling said that is not required. But if in case of addictions, in case of alcohol abuse, in case of cigarette smoking, nicotine, where there is a trigger, a stimulus, he was very rightly, he said, that is where we should try to use this test and see that if we are going to succeed. Else we can try something else and, try showing pictures of, literally show patients with the problem, what they have, so see that they see what is delirium. In case of an alcoholic, show him the cases of delirium. And in cases of substance use abuse, show them the repercussions. Then he will be aware of things. And otherwise, in case of smokers, ask him to put all the cigarette butts in one place and then see the next day what he has done. And he himself will feel ashamed. These kind of things which we can always try. Thank you very much, sir. Thank you, colleagues. Thank you.
Oh, you're very welcome. I'd just like to add one small comment. So I think, and thank you for kind words, all of you. In smoking cessation, I had helped. I'm not going to talk. I haven't prepared case study, but I helped one person who was my classmate, and we grew up together. So I'll keep it very, very brief. But I had used this bringing the behavior from unconscious or subconscious to conscious at the time of picking the cigarette. Meaning, so usually, do I have 2 minutes, Nivedita ji?
Yes, yes.
Okay. So he used to smoke, this two index finger and the second finger, and take the cigarette and smoke. Now, there were like 2-3 sessions, but one of the core thing was I had him change his hand and try it from left instead of right. And that just changing the hand itself was bringing his awareness back into the conditioned unconscious behavior to the conscious thinking. Anyway, so just came to my mind. But yeah, that's all. I didn't want to add anything more.
So that's it. Is there anyone who would like to ask, or we should wind up the session? Sir, should we?
Yeah.
Yes.
I would like to add one point here.
Yes, sir. Yes, ma'am.
May I?
Yes,
Yes,
ma'am.
yes.
Yes, ma'am.
Just a point before this, which was made with respect to smoking, bringing guilt of any kind does not help with progress in long term. It is an emotion which needs to be resolved at the conscious level. So if a person is into addiction, do they carry guilt associated with it? Consciously, yes. But because of cognitive dissonance, which is also our own mechanism, thinking process, they are accustomed to that guilt. And that is why it is not productive for resolving the addiction.
Very true. Very true. So creating guilt in the mind of the person, it's not going to, therapeutically, it's not going to help. You're right. On a
Especially by the
long,
therapist.
yeah, in a long term, it may harm the client. You're right. Okay, so fine. It's a good comment, Reena. And again, I thank everybody and Nivedita and Kate, all the participants. Nivedita, you can
Yes, sir. Yes.
give closing remarks and we close.
Yes, sir. So thank you, Niketji. It was a really wonderful presentation, and it was a very, very interactive session we had today. And really, thank you so much. And we look forward to see maybe your smoking case. See you with your smoking case next time. Thank you. Good night and namaste to all. Thank you.
My pleasure and honor. Thank you.
Thank you.
Thank you.
Thank you, sir.
Thank you. Bye.